for joining the July webinar. So just an update, we've had some technical issues with StreamYard, and for this reason, we're navigating onto Zoom. Today's presenter will be Dr. Kaninji, and I do want to give him a shout out in his flowers. I said flowers. Just giving him a big thank you because we originally had two speakers that unfortunately due to approval process being needed on their end, we actually were considering canceling our July webinar, but Dr. Kaninji really stepped up to the plate and offered to fill in that slot. So thank you, Dr. Kaninji, again for attending and presenting at the last minute.
Absolutely. Are we good to go?
Yes, we could start now.
I could go?
Yes, Dr. Kaninji, you could go.
All right. Good afternoon to everyone. I am delighted to be here with you today to share with you some of the exciting work that we're doing in eye care. I am Dr. Ernie Kaninjing. I am an associate professor of public health at Georgia College and State University. My expertise is in behavioral science. And while I'll be presenting today on one project that Dr. Siedu and myself are leading in eye care, I just wanted with this first slide to indicate that eye care is a consortium with multiple projects, multiple calls, multiple investigators on different continents, all focused on one goal: to eliminate the disproportionate burden of prostate cancer on men of African ancestry. So there are multiple projects, multiple calls, multiple investigators. We're going to focus today on one, but I just wanted to let you all know from the outset that this consortium has multiple projects going on simultaneously. So in terms of the objectives for today, I want to provide you what we sought out to do for phase 1 of our study. I'll provide you some descriptive data on the participants, and then we'll spend the bulk of the time just talking on some of the preliminary results that we had from our phase 1. And then I'll transition to tell you what we're doing in terms of expanding what we started in phase 1 in our current phase of the study. And then we'll talk a little bit about some questions if you have any. But does that sound clear? Emelina, can you hear me good? Is this good?
Yes, I can hear you good.
Excellent. All right, so let's dive in. So the study that Dr. Siedu and myself are focused on is actually a grounded theory study on social determinants of migrant health factors. So we're looking at men who already are impacted by prostate cancer, men who are survivors, men who are originally from sub-Saharan Africa, and trying to understand what are some of the key aspects that is hindering or helping them as they navigate the journey from diagnosis to treatment to survivorship. What are some of the key factors that are impacting them? And here you could see a list of investigators that are part of this project. I mentioned Dr. Siedu. We also have Mr. Lee, who is our statistician, is helping us a lot of some of the data, some of the analysis that I'll be sharing with you is some work that he did. And then we also have now Dr. Hinson from Florida A&M. She defended her doctorate recently, all right? She's part of the study. We have a consumer advocate, Mr. Benessa Erifa for phase 1. And then we also have Dr. Young, who is our mentor and our guide for this study, in addition to Dr. Odedino. So that just gives you the cast of investigators that are part of the phase 1 for this study. So you may be asking, why are we focusing on sub-Saharan Africa? Well, if you know, they are one of the fastest growing immigrant populations in the United States. As a matter of fact, between 2010 and 2018, they grew so much at 53%, which significantly outpaces the 12% for other immigrant groups. It's not just the fact that they're growing, it's the fact that they are not homogeneous. There are significant differences based on the country of origin, based on the culture, based on how long they've been in the United States, all right? Now, the issue is that previous studies or previous studies on this subject are focused mostly on individual behaviors as opposed to also looking at some of the structural factors, so some of the factors that are beyond the control of the individual. So we want to take that into account, not just the individual factors, but also looking at some of the structural factors, all right? So this study would link, would at least fill the void of paucity of research studies that link immigration as a social determinant of health to other factors among sub-Saharan African immigrants. Now, the International Institute of Migration do have a model that they've put out in terms of understanding social determinants of health. And you could see here is our starting point, so this is a starting point. You could see here looking at individual factors, societal factors, living conditions, general economic conditions. We're including that in this model. I want you to pay attention to the cross-cutting arrow on the top, which makes the point that migration cuts across many different domains. But importantly, one of our key hypotheses in this study is that migration in and of itself is a social determinant of health. So we're using this International Organization of Migration model as a starting point, but we want to be very specific about sub-Saharan African immigrants. What are some other factors that may be impacting their health, their survivorship, that perhaps are not reflected in current frameworks or current models on social determinants of health? So for phase one, our goal was to explore structural factors that link immigration with social determinants of health among sub-Saharan African immigrant men. So we want to look at the full range of racial, social, environmental, behavioral, and other factors associated with that population, and also their experience being in the United States. So we want to capture that in a model that would illuminate the social determinants of health factors that are impacting the health outcomes among sub-Saharan African men, because that will help us in the later part of our study to design interventions that are tailored specifically for this population. All right. So what did we do for our phase one? The first thing we had to do was to figure out who are cancer survivors from sub-Saharan Africa. Well, we had to go to cancer registries. So we had to go through a long, arduous process that took 9 months to a year to apply for data on men who have been diagnosed with prostate cancer who are coming from sub-Saharan Africa. Now, one of the problems we face is that many cancer registries do not track country of origin. And so we limited our work to Florida and to Minnesota because these cancer registries do track data on country of origin. And since our focus was on sub-Saharan African immigrants, it meant we had to go to cancer registries with data of diagnosed men where we could actually determine that they are actually from sub-Saharan African countries. Our goal was to interview at least 40 men, capturing the diversity. Again, we mentioned before that this population is not homogeneous. So we're trying to get men from West, from East, from Central, and from Southern Africa to understand their lived experience. All right. We also wanted to, in those interviews, understand their health-seeking behaviors when it comes to the diagnosis of prostate cancer, decision-making, the treatment and care that they pursue, and also their journey into survivorship. So that's what we'll be reporting today. All right. And our goal, again, was to develop a model, which I'll share with you what our preliminary model is. And again, findings from this will be mapped into that International Organization of Migration model that we saw before. All right. Expected outcomes, again, was to develop this model to eliminate health-seeking behaviors, but importantly, to identify specific opportunities where we can intervene. We don't want to design interventions in the blind. We want it to be evidence-based. And so this study actually helps us with some important data that we could use empirically to base our interventions off of. And then we also have some training goals to make sure that we had, as I mentioned, Dr. Hinson, who is on this call, got some training as part of this project as well. So this slide will show you some of the interviews that we did. We've conducted about 16 interviews. You could see from different regions from the continent, from West Africa, from East Africa, from Southern Africa. We're kind of lagging in that area. We're actually requesting more data from different cancer registries. We're actually requesting data from Texas Cancer Registry too, from some other sources to be able to get some of these countries that we couldn't get because the data that we got from Florida and from Minnesota was kind of limited. All right, but you could see here some of our participants, they fall in different age brackets, you know, from 50 years old all the way to 89 years old. Some of them had been in the US just for 2 years, while others had been here longer. And then also when you look at stages of diagnosis, most of them were diagnosed in stage 1, which is the early stage. So that was heartening to see, all right? But then we also see about 6 of them were either diagnosed with late or unknown stage. So this just gives you a feel for the different regions from whom participants from our study have come from. And as I mentioned to you, we had to request data from Florida Cancer Registry. And this slide that Mr. Daniel Lee put together for us just shows you from the data that we received from Florida, you know, in terms of access to care, what can we tell about sub-Saharan African immigrant men who have been diagnosed with prostate cancer? A lot of them do have access to care in terms of insurance. But if you take a look somewhere down here, some of them are not insured or insurance unknown, right about 5%. So not all of them do have insurance access. So we know insurance is actually a proxy for access to care. We saw about 5% of them did not have that access to care in terms of having health insurance. Many of them, as we mentioned in the previous slide, were diagnosed with localized disease. And this is just from the Florida Cancer Data System, the cases that we got from Florida. We could also see some of them were on stage, a few of them was stage 4 or distant, that spread. Now, in terms of treatment that they receive, all right, so this slide is showing you the treatment type. So you could see the different treatment type that they had received, some not given treatment, some doing, to the left, you have active surveillance, so watchful waiting, some not given treatment yet in the middle, but the majority of them were receiving treatment. The majority of them were receiving treatment. And then this slide just shows you the different countries from which they came from. All right, again, from East Africa, from West, from Southern. This just shows the different countries and also the age groups. So to your right, you could see the different age groups that were represented. To the left, you could see the countries from which our participants came from in terms of country of origin in Africa. And then again, this just shows you stage at diagnosis. So most of them were localized. All right, so in terms of the emerging models, so this can be broadly categorized into 3 key areas. The first key area are the health behaviors, the health-seeking behaviors that were exhibited by the men that we interviewed. The second category is really about their decisions about the treatment that they receive and how they're navigating their symptoms or side effects. And then the last category is that what we mentioned before, that being an immigrant is a social determinants of health in and of itself. So the third area, they just talk about the challenges of being an immigrant. So let's start from the left and work our way to the right. Now, in terms of the health behaviors, we notice that some of our participants use over-the-counter medications to deal with some of their symptoms, all right? Many of them were actively searching for information about prostate cancer after they were diagnosed. They were also making adjustments to their diets and getting exercise based on recommendations from their treatment team. Now, below health behaviors there, you also see one intriguing phenomenon that we uncovered about this population was the use of informal care team. So participants will use their social network as a sounding board for some of the treatment that they receive or about making decisions about which treatment to pursue. Next to that, we also have the behavior of selective disclosure. So our participants were very mindful of whom to disclose their diagnosis information with. Some would disclose that to family members, others were reluctant to do so. So those are some of the behaviors that were exhibited by the participants in our study that we interviewed. Now in the middle section, we're going to talk about their treatment and how they were navigating that. So interestingly, a lot of them made very quick decisions about treatment. So once they were diagnosed, they wanted to move right away to treatment. All right. So some of them, as we mentioned before about selective disclosure, some of them were reluctant about sharing news. All right. Some would seek a second opinion and also evaluating the recommendations that they were receiving from the treatment team. And also something that we notice is decisional regret. All right. Some of them were making fast decisions and sometimes regretting the decisions about the treatment that they pursued. Now, still under their treatment and the decisions they were making, all right, a lot of them were dealing with side effects like pain, incontinence. Incontinence was another side effect from treatment that was prominent in the data that we got from interviewing these participants. Some of them were dealing with fatigue. And then a lot of them were also dealing with reduced sexual function, as you might expect, depending on the type of treatment that they're receiving. Now, the psychological effect was very, very strong. Social isolation was a big, big factor. Social isolation, lack of self-esteem, also dealing with mood changes as a result of the treatment that they were pursuing. And then for a lot of these men, being diagnosed, going through treatment just brought them thinking about their own mortality. In terms of coping with the diagnosis or with the treatment that they were receiving, a lot of the men relied on their faith. So a lot of men rely on their faith or their religion, some on their family members, also, especially family members who had experienced that same condition. And then they also got support and advice, again, from family members. And as I mentioned before, exercise and changing their diet was also some coping mechanisms that some of our participants exhibited. Now, making our way to the right of the screen, the challenge of being an immigrant. All right. So one of the key practical stuff that participants were dealing with was just that separation, that loneliness, separation from being away from loved ones who were thousands and thousands of miles away, still in sub-Saharan Africa. For others, English may not have been their first language. So the challenge of learning a new language while they're dealing with treatment, trying to understand what the physicians and the treatment team was sharing with them. So for some of our participants, dealing with a new language, a new culture was a challenge. Some of them did not quite have work authorization yet or needed help with transportation to get their care. And then we also had instances of mistrust of the provider, not sure if the provider was giving them the best possible advice. Still, under the challenge of being an immigrant, we also have knowledge gaps about the US healthcare system. We all know the US healthcare system can be complicated and difficult for even people who've been here longer to understand. But we found out that some of our participants did not quite understand copay, deductible, and some of the nuances of the healthcare system here. And many of them, based on their cultural background, were not very assertive in terms of once they do get that appointment in front of the provider, really initially upfront telling them what their needs were, what their values are, such that it could be incorporated into their care and treatment plan. So that lack of assertiveness is also something that was coming from the data. Now, in terms of the support need, we mentioned insurance coverage rather. Initially, I showed you about 5% in our data set did not have health insurance. We know how costly that could be if you're paying out of pocket in terms of adding stress, not just dealing with your treatment, but wondering how you afford paying for the bills. Also, support needs reduced out of pocket. You may have insurance, but does it really cover all the basics? And then transportation needs. But importantly, we talked about the challenge of being an immigrant. What we also saw from the data was strong resilience, a positive mindset, not wanting this diagnosis to define them, avoiding self-pity, which also goes back to some of the quick decisions they're making. Well, now that I have this disease, what can we do about it? So it wasn't just the challenge of being an immigrant, we also saw strong resilience of having a positive mindset, despite getting some news that could be very debilitating. But they did not want to dwell on self-pity, but they wanted to move on to take steps to address the diagnosis. So just to give you a flavor for some of what the participants told us, for some of the key constructs that are emerging from this model, I mentioned that informal care team, which is the use of friends and family members or social network unconnected to their current treatment. So here's a participant mentioning that I do talk to doctors from back home. So doctors from the country of birth who are practicing here in the United States. So I was able to reach out to two guys, two medical doctors and another family member who lives in Canada, but he's not, practicing. So he says, I have an informal care team that he was tapping into. Now, when it comes to that quick decision on treatment, one participant mentioned, the first question I asked my doctor was, I said, what will be the final result on the effects on my life? Okay, the bones may crumble. Maybe that may when the bones crumble. But the point here is, what can we do right away to address this? And you also see about decisional regret, not feeling that the doctor really took into consideration their values, what was important to them. So this was a 71-year man from West Africa mentioning decisional regret. And then we had social isolation, somebody dealing with the side effects from treatment. They are dealing with incontinence, and the incontinence sometimes is causing a situation where at work, he's having challenges. As a result of that, he doesn't want to go out. He doesn't want to go to public places, will not even go to church because of that lack of self-esteem, all right, that is coming from incontinence, not being sure, if he's in a public place, what could happen with his incontinence. So that really psychologically impacted some participants as a result of, navigating their treatment and care. They became more socially isolated and were reluctant to go into public places because they were trying to avoid some surprises. So because the whole process of treatment, we deemed that to be very important, we were trying to dig deeper into that phenomenon to understand that process of treatment. And this is not fully fleshed out yet, but this is what is emerging from our data so far. So once the men are diagnosed, you see an arrow going here. Some of them will try to get recommendations from their doctors. A few of them will get second opinion. But you notice they want to go right away into kind of treatment decision. All right. So understanding what options are available to them. All right. Making a decision about treatment. And then when they're in treatment, you see the dotted arrow comes to your left, talking about the potential side effects that some of our participants are dealing with. All right. And then initially here, again, too, upon diagnosis, we see a wide range of reaction of fear, of fatalism, of shock. All right. More solution oriented. What do we do right now? All right. Also some mixed feelings, seeking support, resilient, and faith. So these are all reactions right at that point of diagnosis. And then we also talked about coping. All right. Coping right here about, their faith, their family, okay, tapping in some of that resiliency that they had coming all the way back from the home continent. And then this is just, again, touching back on that mistrust of the healthcare system. All right, communication issues. Remember, we mentioned some of them English is not their first language. All right, so communications issue or lack thereof is creating mistrust with the healthcare system. And then again, we talk about decisional regret, painful treatment or unsuccessful treatment, or in some cases, unforeseen side effects that is making them doubt their initial decisions to pursue that treatment option. So this is just a presentation that we did for AACR, summarizing some of the key findings about some of the key themes that I just mentioned, treatment, informal care theme, and all of that. So that gives you a nutshell of the results that we're getting for phase 1. And just keep in mind, phase 1 was focused just on immigrants from sub-Saharan Africa. Now we decided to expand our population of interest for phase 2. So we're sticking with the same overall theme, addressing social determinants of health factors impacting survivors. So we are including this time not just sub-Saharan African immigrants, we'll still focus on them, but we're also including immigrants from the Caribbean. So for phase 2, we're expanding our population of interest to include Caribbean immigrant men as well. So this is our team for phase 2. You see myself, Dr. Siedu, Dr. Young, Mr. Agbola, who's our consumer advocate, Mr. Lee up there. We're also collaborating with colleagues from MD Anderson, Dr. McNeil, Dr. Pettaway. We also have a consumer advocate from the Caribbean immigrant community, Mr. Beckford. We also have Ms. Van Vorish. So in terms of our background, we already mentioned the fact that sub-Saharan African immigrants were a growing population. Yeah, when you add the Caribbean immigrants together combined with the African immigrants, they represent 88% of all foreign-born Black people in the United States. We know that Black ethnicity is a risk factor for prostate cancer. So we're saying when you combine these two populations, despite their rising numbers, the health needs and the practices of this population is not fully understood. So what we're trying to do, similar to phase 1, we're examining the social determinants of migrant health factors, again, including Caribbean immigrants, in addition to sub-Saharan African immigrants. And we're saying knowledge that we'll gain from this study will really inform the development of social determinants of migrant health interventions, again, to address the differences in health outcomes that we're seeing among these populations. All right, so again, we'll be seeking health, specifically health-seeking behaviors, decision-making about treatment care, psychological effects. So all the aspects that we explored for sub-Saharan African immigrant men, we'll be exploring that for Caribbean immigrant men as well, all right? And then once we create that, we'll be trying to test the efficacy of these emerging models. We'll try to test those efficacy. And then based on that, based on the sub-Saharan African immigrant men social determinants of health and also the Caribbean immigrant men social determinants of health model, again, we will plan, we'll develop, we'll test an eye care VERA intervention that will provide navigational services for these two populations. When we talk about the eye care VERA, we're talking about virtual reality assisted solutions that can actually help navigate these men based on their needs. We're trying to be very nuanced about this. We're trying to be very tailored. We believe that one size don't fit all. Once we understand what is the need of this particular individual, we will tailor interventions to address their specific need. So expected outcomes, again, we seek to eliminate the health-seeking behaviors and experiences of these two populations. And again, we will design interventions to address barriers to care by developing and testing tailored interventions. So that in a nutshell gives you what we did for phase 1. It tells you what we're going for phase 2. And I just wanted to stop right there and see perhaps if there are some questions that I might be able to address. Thank you.
Thank you, Dr. Kaninjing. I see some questions in the chat, but I also see Dr. Amanisi's hand is up. So Dr. Amanisi, do you want to ask your question?
Yeah, thank you very much. Thank you so much, Dr. Kaninjing, for that brilliant presentation. Just to comment and also ask another question. Way of comment, I agree absolutely. As a physician that I've practiced in Africa for more than 2 decades, I can confirm for you for free that our colleague does not lay emphasis on social determinants, outcome, particularly when it comes to diseases like prostate cancer. People tend to focus on the symptoms, clinical features, and we know that the social, determinants are very, very key because they determine the outcome of many of those patients. So thank you so much. Very, very stimulating, work you have done. I want to find out, you make reference to further cancer registry and some, cancer registry in the Southern Africa. I was expecting to hear some names of some of those registry. I don't know if you can just mention some of the registry that you collaborated with, because we may recommend some. There are some of that have done very well, and they have robust data on prostate cancer. that we can recommend so that you can collaborate in your future work. Thanks, Anova. Thanks for the great work.
Thank you so much, Dr. Monisi. And you're really right about it's important to focus on the treatment, but it's also important to address the social determinants of health. So, for example, if the physicians are designing a treatment plan that requires that patient to come to the hospital 3 or 4 times a week, do they have the transportation to do so? Do they have the support at home? So those are all some of the key things that we're trying to figure out. How do we help the men navigate some of those aspects? Because that is integral to their care. If they don't have that support from home, they don't have that transportation, then the treatment plan may not be as successful as initially designed. Now, to your second question, yes, so we're working with Florida Cancer Data System. We're also working with Texas Cancer Registry. Thanks to Mr. Daniel Lee, who connected us with Texas Cancer Registry. And then additionally, we're working with MD Anderson Cancer Center in Houston. So I know Professor Dedina is planning a trip there with some colleagues from iCare to strengthen that relationship with MD Anderson Cancer Center in Houston. Dr. Monisi, as you know, there are different laws from different states that guide different cancer registries, and sometimes a very challenging road for investigators to get that data set, but we're working patiently with some of these cancer registries. We had some very challenging experience with Minnesota, so we opted to go seek Texas Cancer Registry for phase 2 as opposed to Minnesota Cancer Registry. Those are the ones that we've worked with so far. Thank you.
Thank you. Thanks.
That was a great question. Thank you, Dr. Kaninji. Other questions that I have within the chat. So first question we have here is, did you look at age of diagnosis and how does it compare to African Americans? I believe this was near the beginning set of your presentation. And the follow-up question with this is, are the stage at diagnosis comparable to the stage at diagnosis for African Americans?
So for this, for this study, you can see a lot of the ages we got mostly from 50 to 80 to 89. Interestingly, we didn't get people in the 40s. We know they exist. So it goes back to also working with the cancer registry, where we also had questions whether the country of birth sometimes was not accounted for in all cases. So we definitely believe we're missing some people there in the 40s, because we know that men of African ancestry are getting prostate cancer. Some of them are getting them at an early onset compared to other populations. For this data set, we're only seeing men in the 50s. So we know that the cancer registries that we're getting, and these are for the men that we recruited, all right? So I can provide you data for what we receive overall, because Daniel completed that. You can see right here, but still overwhelmingly showing men from 50s, 60s, and above. But we know that that is not the true reflection. So this also points to some of the weaknesses when you're recruiting from the cancer registry. They may not be picking up men because of that country of birth. It's not something they've been doing traditionally. They just recently started doing that. As a result of that, we may be missing some men who were born in sub-Saharan Africa, who are 40 years or between 40 and 50, that are not reflected in this data set.
Got it. Helpful. Thank you, Dr. Kaninji. I see comments saying all the great work that you've been doing, as well as another comment/question that it would be good to see how these themes compare to the themes from the primarily African Americans and Caribbean themes from the CAPCAS study.
Absolutely. So we definitely explore that. And that's why we're looking at sub-Saharan Africa. We'll look at Caribbean immigrants. A lot of work had already been done on African American men. So yes, we'll definitely triangulate that data, taking a look at those distinct populations and then seeing what similarities or differences are emerging. Absolutely. Yes. We'll also triangulate that with the CAPCAS data as well. Yeah.
Perfect. And this is a comment for Dr. Amanisi, but for Dr. Amanisi, Dr. Denna just wanted to share that Prof. Saleka is working on a cancer burden project that includes social determinants of health.
Yeah, I just want to give a shout out to, again, Dr. Siedu is here, Dr. Hinsom is here, Mr. Daniel Lee. So all the slides with all the descriptive statistics came from Mr. Daniel Lee. So he did some work on that. I just want to give a shout out that this is a collective effort. So I may be presenting the results here, but it's a whole team effort that has worked together for this.
That makes sense. And I love that about iCare. It's just all the collaborative effort among all the MPIs. So some additional questions within the chat, Dr. Kaninji, that we have. So mentioning how this is a really great and exciting presentation. SDOMH is one of the most important aspects of cancer continuum that is largely ignored. So question number 1, what is your opinion about prostate cancer support group? There's a comment associated with this. So I can read that now. So
No,
comments.
I can just respond to that. It's a very,
Okay.
very effective. In my collaboration with in a separate study with Dr. Ogunsanya, we have Dr. Adedipe now. We have a strong support group. We're meeting monthly. It's you can't believe, first of all, to see the growth of the men. As part of that support group, some of them were just newly diagnosed, not knowing how to deal with this, but drawing strength from other men who are able to share that story. We've seen men move from just being survivors now to becoming advocates. All right, so some of the advocates, Mr. Bedford, who is a Caribbean immigrant man in this study, was pulled from that other study where we have a support group going on. So I encountered Mr. Bedford, who is part of the Caribbean immigrant men, was part of the other work we're doing with Dr. Adedipe, where we actually have a strong support group. So I've just seen a lot of good things happen among support group with the mentoring. Remember, we mentioned that we're having early onset, and these men are actually coming up with ways of engaging men back in high school. They want to go back. They say college may be too late, trying to talk to Black men that early because they have the lived experience. They have the lived experience. They know how, in some of their cases, the diagnosis was not made till later on, and they're trying to change the paradigm by saying not just having conversations at dinner time, at Thanksgiving, or whatever. Let's start educating Black men much earlier. So I strongly believe I've seen the power of support group and how that can really change the psychological impact, the psychological challenge that men with isolation, we talked about social isolation, but being part of that support group helps to take away some of that because you're working with men who understand the journey you're going through. So it's a powerful way, and we strongly encourage them. We're actually creating one in my local community in Milledgeville, Georgia.
Love that. And it does. It's so powerful. So that was a great question asked by Renzi. Additional comments associated with that initial question was, while I understand that SDOMH is the focus, I was wondering if you would be thinking to discuss these results in line with something like political determinants of mental health, PDOMH. I don't know if anything like this exists, but political power is now determining whether a Black man lives or dies.
No, that's a great comment. So if you take a look at the title of our study, we're doing grounded theory. So whatever is emerging from the stories that the men are telling us, we will definitely pursue. So if that is emerging, because our methodology is to have a study that is grounded in the experiences. And as those experiences come up, we will definitely pursue them. So we're definitely open to whatever the participants is telling us as their lived experience. Absolutely.
Experiences. Yep. There's 2 additional questions in the chat, Dr. Kaninji. So one of those questions is hoping to understand that 88% Black immigrant men in USA data, as Puerto Rico/USVI populations are domestic and not part of the immigrant data set, but their gender breakdown is around 48% male. Are you all or only some island nations?
Excellent question. So that's a good thing because Puerto Rico, a lot of them have that African ancestry background. So perhaps that's you give us a food for thought, perhaps a further expansion. We started with sub-Saharan Africa, we went to Caribbean. Perhaps the Puerto Rico population may be our 3rd expansion. So that's definitely food for thought because Puerto Rico, again, a lot of them have that African ancestry, which we know is a risk factor for prostate cancer. So that's food for thought, potentially expanding not just with African, with Caribbean, but also Puerto Rican men as well.
And the last question that we have here that's in the chat is thanks, Dr. Kaninjing, for the wonderful presentation. I would like to ask if there are modalities that can be put in place to help patients navigate the issues relating to access to transport to health care facilities for treatment.
Excellent point. So that question put their finger on one of the objectives that we were trying to address, not just looking at individual factors, but also structural. All right, so structural. So we're trying to see, for example, what we noticed, especially for phase 1, we noticed that a state like Minnesota has a very good support system in terms of men, in terms of the care that they get. So one of the things we're looking at is what is Minnesota doing so well that perhaps might be lessons for other states to cover men in terms of, because Minnesota, they had some of the men we talked to, they had some very good, for example, transportation to care. They got access, they got transportation provided for them. So one of the key things we'll be looking at the later part of this study is those recommendations. So what could we recommend in terms of addressing those structural, those factors that perhaps are beyond the capability of just an individual? We're seeing some examples in some states that are doing it well. We would definitely want to pursue that some more and see how could that be replicated in other states to reduce the barriers in terms of access to care, so that men who need the services can have it at a time that's important for them for their journey, while reducing as much red tape as possible.
It's a great response. Thank you, Dr. Kaninjing. I just wanted to ask if anyone else has any additional questions, comments, feedback for Dr. Kaninjing. So what's in the chat, Dr. Barbell Johnson was just sharing how a great talk that you had, and she also learned that genetic studies show specific risk-related SNPs/genetic variations. Example, RS 7824364. I'm sorry if I missaid the numbers. Linked to increased prostate cancer risk in African ancestry in Puerto Rican men.
Absolutely. Similar studies done by Dr. Murphy Adams and others had seen the 824, the long arm chromosome among men from Nigeria and Cameroon. So the important thing is that while we're studying these populations here in the United States, we also have colleagues in Africa who are doing similarly. So basically, we're trying to address our knowledge deficits about this population by engaging in studies not just here in the US, but also in Africa. So we're mindful of the fact that while we're working with African immigrants, the source country was, it's important to understand the conditions in the source country that is contributing to some of the health outcomes that we're seeing here. So we're definitely collaborating with the ABBA Center with in terms of some of the work that they're doing there. So because we try to understand the health behaviors, the social determinants of health, not just here in the US, but also back in the home country, because that's having an impact in terms of their behaviors here in the US.
Thank you, Dr. Kaninjing. Great. It's a comment from Renzi saying, I wanted to thank you very much for the use of grounded theory. Sorry, mute. Okay. Okay, I can't mute. There we go. And they need to, because we need more rich and robust data that helps to explain process of lived experiences and exploring a Black-driven theory for our race. So well done. Okay. Oh, Renzi. Oh, you have your hand up. Did you want to ask your question? Comment?
Yeah, I just want to expand on that. Dr. Kaninjing, I was so happy when I heard about this method session you were talking about, because I'm currently doing some research on prostate cancer, and I realized that we don't have a lot of theories or even qualitative data that are driven, that are actually from. I only just found one that was done by Prof. and you. I think Prof. you and Dr. Fullwood So I didn't find many. But when you check in other population, like, other populations of men, you will find a lot of theories, you'll find a lot of process-driven articles. So I just want to thank you so much, because I think this is really important, because the lived experience of our men is so different from, other men of other race. Well done.
Mr. Chidebe, you put your finger on a very, very important issue. So we have to change the paradigm. It's not been done. We can't expect other people to come doing among this population. I know the work you're doing right now in your doctoral dissertation will also be important, contributing to addressing this. When I started over 10 years ago, I was searching, couldn't find. When I fell on the work of Dr. Dedina, I just went crying and went to Professor Lomango, and he took me to Dr. Reams and then to Dr. Dedina, because it provided the roadmap for what needed to be done. Currently, Dr. Bolajeko and myself and Dr. Siedu have some frameworks that we are about to submit to the press, trying to address the lack of frameworks that illuminate health behaviors among these specific populations. To your point, we cannot just transfer instruments or frameworks that have been used among different populations and assume that the same thing is true for populations of the Caribbean, of Puerto Rico, of sub-Saharan African immigrant. We have to do the work to empirically prove that. So your contribution too is definitely important, because we may also want to look at within sub-Saharan African populations, what are some of the differences. So the work that you do will also have to inform and then create a baseline that other studies can build on that foundation. So thank you too for the work that you are doing.
Thank you. Dr. Dedna, you have your hand up?
I wanted to detail that, but I want to give the credit to where the credit is deserved. The whole movement of doing ethnographical study is from Dr. Mary Ellen Young. She is the expert, and she was the one that worked with me, and I believe is the first original study on ethnographical studies in Black men in the United States. So I just wanted to give Dr. Young a prompts. We're so happy that you could attend today, but she literally really changed the dynamics of how we look at prostate cancer in Black men globally through a strong grounded theory and ethnographical methodology. So I want to make sure that we give her flowers. She's the one that owns those flowers.
Exactly. She did the good, the bad, the ugly.
You are so kind.
Everything. She's
you are so kind.
Power behind all those theories.
I think this just shows that, yes, the power behind the methodology and the what we learn when we actually listen to people tell us about their experiences. So I love all of you.
We love you too. We love you too, and we're praying for you. And Ronsi, if you have not personally met Dr. Young, give her a couple of months, but make sure that you reach out to her and talk to her. She is the guru of all this work.
Wow, thank you so much.
Thank you so much, everyone. Thank you, Dr. Kaninjing, for a great presentation and for taking the time to answer everyone's questions and comments. So I believe this concludes our July webinar. And again, thank you all for being flexible and attending the Zoom versus the StreamYard. We hope for the next...
Stop. Can I just say something? I just want to introduce Dr. Olufikayo Bamidele, who is going to be leading our work in United Kingdom. I don't know whether you can unmute yourself and introduce yourself, Dr. Bamidele. Are you able to unmute yourself? Yes, we are so happy to have you on. Go ahead and introduce yourself, please.
So sorry that I had to join late because I was just joining in between meetings. It's already till 6 here. So apologies for that. But thank you so much, Dr. Dedino. Thank you so much, everyone. So my name is Olufikayo Bamidele, and I'm based here in the UK at the Hall of Medical School, University of Hull, and my research looks at the psychosocial aspect of cancer inequalities. We're basically focusing on prostate cancer in Black men. So doing some work here in the UK. And it's very interesting what you were saying about grounded theory, because that's also kind of my area of methodological interest and passion. Really, yeah, so really looking forward to connecting with people and collaborating and on this exciting journey. So thank you again, Dr. Dedino, for this opportunity. I'm so grateful. Thank you.
Yeah, thank you. Sorry, I just had to introduce her because as we're doing work in Africa and we're doing work in North America, she literally is the one woman power who's going to be pushing this kind of work in Europe and United Kingdom. So the connection, we had a great talk. We're talking about Dr. Kaninjing's work and how everything ties together. So this is very powerful to really do have all these connections of Black men across the world, and we're getting the data to be able to do this work. Phenomenal work. It's so great to have you.
Big shout out to you, Dr. Bamadelli. So I'm really excited to see all the progress and that we'll be doing in the UK and having you help lead that.
Thank you very much. Thank you.
All right, everyone. Thank you again for attending, and I hope you have a great rest of your Friday. Beautiful rest of your weekend. All right,
Bye.
thank you. Bye-bye.